So, ladies and gentlemen, welcome to our webinar to celebrate the World Antimicrobial Resistance Awareness Week. Bienvenue à toutes et tous, bienvenidos a todos. My name is Rodolphe Meder, and I am a science advisor at ICARS, which is the International Center for Antimicrobial Resistance Solutions. As you may have guessed, I can speak English and French, but I'm a very poor Spanish speaker. However, it does not matter today, as our event will be live translated in Spanish as well as in French, thanks to a great team of translators. That being said, let me welcome you once more to this ICARS webinar on moving from evidence to policy, mitigating AMR across One Health sectors using intervention and implementation research. Today, we will have 4 guest speakers. Dr. Sujit Chandy, Executive Director at ICARS, will give us a keynote introduction on the ICARS approach for moving from evidence to policy. Then we will give the floor to 3 lead researchers of ICARS-supported projects. They will speak about their own experience in bridging the gap between evidence and policy using intervention and implementation research. Professor Victorien Dugnon will share the experience of Benin, Dr. Marika Tsereteli, the experience of Georgia, and Prof. Raka, the experience of Kosovo. If you have any general comment or technical issue, or if you wish to introduce yourself, feel free to use the chat box. If you have any questions to the speakers, please use the Q&A box. You can type in questions in English, French, or Spanish. Finally, I would like to remind all those speakers not to speak too fast, as a couple of people are translating what you say in the backstage at any given time. I think we are now ready to move on. Dr. Sujit Chandy, the floor is yours for your keynote introduction.
Thank you very much, Rodolphe, and thank you for the opportunity to, on behalf of ICARS, to take part in this webinar, which I think is extremely important, mainly because the world is now transitioning from planning to actual implementation, and therefore this whole issue of how do we move evidence to policy, to practice and implementation becomes extremely important. And therefore, the country examples which are going to be discussed in this webinar will prove a very important stimulus for other countries and other research partners and governments who would like to move from evidence to policy to practice, the ICARS approach. Next, please. So I think we are all, whoever's hearing it, realize the situation we are in, where the globe has this threat of antimicrobial resistance, but it's a perfect storm. And what do I mean by a perfect storm? We're not talking about the weather, nor the violence in the world, nor poverty, though all, of course, affect antimicrobial resistance. We are talking about a situation where on the left you can see all those wonderful antibiotics discovered over a period of time, especially in the last 6 decades or more. But many of them are not able to be used because they lack effectiveness because of the phenomenon of antimicrobial resistance. At the same time, with the rising AMR, there is a decrease in the research and development of new molecules of antibiotics. And there are many reasons for that, which I don't want to go into. Of course, we can increase the R&D if there's money, but at the same time, if we continue to misuse or overuse antibiotics, we all know that there is a strong association between that and rising antimicrobial resistance. And that is why we need to not just wait for more drugs or wait for the bugs to actually increase their power with resistant strains, but try and do something else. Try and find out what are the models in the community, in the research institutions, in the various sectors, which can work through evidence generation, and moving that to policy and ensuring that the policy then gets implemented into practice. Next slide. And if you look at that next slide, and you've closely observed the literature and what we experience in everyday life, there is definitely a gap between evidence to policy and from policy to practice through implementation. So the real question is, how do we fill in that gap? We cannot afford for that gap to widen. We should be narrowing it, but with a sense of urgency. Next, please. And when I say these gaps, I also want to emphasize that sometimes it's not easy to automatically transform evidence into policy or guidelines, and much more difficult sometimes to implement those guidelines into actual good practice. And we all know that in our respective countries. Sometimes more difficult, sometimes less difficult, depending on the sector, the culture, the practices, the resources, the money. But whatever we do, we need to ensure that these 4 areas which are on this Venn diagram are focused on. Whatever we do, we need to ensure that the benefit is greater than the harm. We need to ensure that whatever evidence we generate, it should be relevant to the sector and the community and of the highest standard, so that policymakers, when they really want to ensure a movement towards action on the ground, they have the full trust of that evidence. We need to be sure that the values that each sector, each profession, each community encompass in their own daily lives is kept at face value. And last but not the least, there is no point in creating evidence which is so costly to implement as action that many of our countries will not be able to afford it. So if you go to the next slide, we at ICARS, which is an independent self-governed organization originally set up by the government of Denmark, but with a vision and mission, not just to reduce drug-resistant infections across One Health, but to try and do this by partnering with countries, looking at their needs, their priorities in the AMR National Action Plan and their research priorities. And for us, that is very important, because yesterday I was at another webinar looking at needs assessment. If we have a pre-programmed way of doing things, we might create evidence, but does it fulfill the need or the gap which is existing in that region or that country? Because only if we fulfill the needs and priorities of a country or a sector will there be buy-in and sustainability. The second thing that we really try to follow is try and generating that evidence on AMR solutions that work in real life. Many a time in the research world, we don't look at many things around. We try and focus on efficacy rather than effectiveness. And sometimes that's an artificial way of doing things, because once we move that evidence generation into the real ground, many factors may be there which act as barriers or impede its effectiveness. And that is why for us, it's important to understand the context where we are, to understand the beliefs and the practices of those in the community and the sector, and most importantly, that they understand why there is a need for a particular intervention. And together, strengthening that partnership is essential if we want to work in real life. And that is why we look forward to partnership in a different sense, partnership in an equal sense, but with the needs of those we serve the utmost. And we follow, in many of our projects, an intervention implementation research framework. And what do I mean for those who are not familiar with this term? There are many things which are evidence in literature already. Antibiotic stewardship, for example, in human health, biosecurity in farms, for example, in the animal world and the agricultural world, as two simple examples. They could be interventions, and we know they work, but do they work in certain contexts? Do they work with certain other factors at play? And that is where the implementation part of it, the science of it, the framework of it, looking at behavioral change issues, the economics, and not just the science, come into play and are studied. And for us, that's very important, because if we get the model right in any country and we disseminate those results, it is very important for another country or region to understand what were the barriers you faced, what were the issues in behavioral change or economics, so that they can tweak that model for their own purpose. Doing this in this way, therefore, allows, in my opinion, sustainability and scalability. But there is one more aspect, as the next slide shows. If you really want sustainability and scalability, there has to be a top-down, bottom-up approach. And this is very important, because if you finish a project and it's a very successful from a science point of view, what is the guarantee that any government can move it forward from there to the rest of the country, or for that matter, the rest of the region? There needs to be a buy-in from the government right in the beginning. And we do that with a memorandum of understanding and, of course, looking at their needs. But it is also important to involve the research institutions so that the science of it and the rigor of that evidence generation is optimal. And third, not the least, but actually the most, we need to involve those on the ground, the community and the stakeholders in the sectors, because finally, they are the ones who have to believe in a model that it works and translate that to action on the ground. And that is our approach. And we strongly believe if we need to fill in these gaps, as I mentioned in the early on, this has to be done through a top-down, bottom-up approach with our partners, both in the country and internationally. Next, please. This is where we're at now with this kind of a model. Across the various sectors, as you can see with the different icons, whether it's agricultural, animal, whether it's human and environmental, but across the various countries, the various continents. Of course, we are very fortunate that we have the funding, and we are so happy that the government of Denmark and our other funding partners contribute to this model and to the work in these countries. But it is very important for us that as we try and fulfill our vision and mission, that more countries and more partners join us in this very important exercise towards optimal implementation. And therefore, in the next slide, let me close by saying that these examples which are going to be brought to us are crucial to disseminate, but also as models for their regions and similar contexts throughout the world. Thank you very much for your patient listening.
Thanks a lot, Dr. Sujit Chandy, for these introductory remarks and insights. As you just said, we will now transition with the experience sharing session from 3 countries, and we will start with Benin. Professor Victorien Dugnon, the floor is yours for your presentation. You have 10 minutes. Remember, don't speak too fast for the translators.
Okay, thank you very much. This is my real pleasure to talk about the feasibility of a certification system, experiences from Benin through the project regarding reducing the import of antimicrobial resistance through day-old chicks and hatching eggs imported into Benin. Next slide, please. So I will go quickly through a contest, what we call mix and how it will work in Benin, what is the feasibility and how the policymakers and stakeholders were supporting each other during this mix preparation. And I will end with some challenges and some lessons learned. Next, please. So as context, next slide. You know, this poultry production for eggs and meat is a vital source of animal protein for human nutrition. And in Africa, especially in Benin, chicken is the most consumed meat. And the poultry sector contributes a lot to the agricultural system. And this could grow now because since last year, the government is banning the poultry imports that will start in December. So we are going to see increasing of national item on that respect. Next, please. And that's come to the antimicrobial resistance because the animal production leads to a big usage of antibiotic. And those antibiotics are used in human and veterinary medicine. Many studies show that in commercial chicks in Nigeria and also in Benin, we reveal that imported day-old chicks can be some reservoirs of microorganisms that are already resistant to critical antibiotics. Next, please. And through our ICARS project, we went to some CAP studies, and we noticed that the imported chicks in Benin, they don't undergo microbiological testing, and that highlights the need for a mix following a feasibility studies. And health control in Benin, particularly regarding the microbiological quality, when you look at salmonella, for example, and also the movement of chicks are really insufficient. And this is a threat to public health. Next, please. Thank you. And we also noticed that effective policies are crucial in the fight against antimicrobial resistance. And then a robust policy is then essential to effectively control the introduction of antimicrobial resistance through the importation of day-old chicks and hatching eggs in Benin. Next slide. That's where our idea came up, to establish a microbiological certification system for imported day-old chicks and eggs, proudly supported by ICARS. So what is the mix and how it will work? Next slide. The mix is the microbiological certification system platform. And we hope that this platform will employ quantitative PCR techniques, which will allow real-time detection of genes specific to the bacteria of interest. We are including E. coli, Salmonella, and Enterococcus faecalis. And this similar method was used during COVID-19 pandemic in Benin. And in case of positive detection, the bacterial culture and antibiotic susceptibility testing will be performed, and this could take 72 hours. The platform will be used to test the day-old chicks and hatching eggs imported into Benin. Next, please. Therefore, when we are taking this into consideration, it's come to this picture. You can see from the beginning, the formal route, airport, and the informal route through the local borders. We have the day-old chicks imported and the hatching eggs. We sample the dropping from the box. We sample some hatching eggs, and we go through stomata and bacterial culture on chromogenic media. We perform all the different steps regarding the antibiotic sensitivity test, the DNA extraction, and we have the computerized platform for the dissemination of the results regarding the microbiological test carried out on those chicks and hatching eggs imported in Benin. And the results will be disseminated with the Ministry of Livestock and also the Livestock Directorate so that they can inform the importers and the poultry farmers. the possible, please come back behind, the possible decision could be that an incineration, an authorization, or a warning. Next slide, please. So what about the feasibility? Next slide. We ran a study of feasibility, and generally we show that this mix is feasible because we had some grade on 4 out of 5 on many items. So the administrative feasibility seems very satisfactory. The technical feasibility looks nice. The logistical feasibility was fine, and also the economic and social feasibility seems very satisfactory. And we had, through the whole project, the full support from the Ministry of Agriculture and Livestock to implement the mix. He's even from the beginning of the project willing to support really this mix. Please, next slide. So the estimated budget for the implementation is there. The sample analysis cost is around $35 USD, and we are expecting per year 480 samples per year. Next slide, please. So how did we make this good fusion between the policymakers and stakeholders? Next. The stakeholders were really engaged in every step of the preparation, from the project itself till the end. It's not like we wrote a project and we gave it to them. No, we co-wrote this project through the different work packages, and they know where the institutional support needs to be. We, during the service, they participate, they give us the contact with all the institutions related to the ministry, the poultry farmers, the association, the private veterinary services, and all the services were open for us because they feel involved in the project. Each work package had the step between them and us. That's how we move together from the beginning until the end. And we had also many workshops to discuss what we find. We had this feedback together. Next slide. But even if everything was so good, we had some challenges. The first one is the limits of the mix, because we have the persistence of an informal channel for importing day-old chicks. And even the government is not enough to fight against this limit. Next slide. We had also the emergence of new resistance, not integrated into the initial mix system. Next slide. We have the insufficient legal framework governing the operation of the mix. That is one challenge we are working on, especially through our last meeting. So our perspectives and solution is to strengthen the legislative and regulatory framework for the proper functioning of the mix. Next slide. Also strengthen these control bodies and intervention frequency, particularly regarding fraudulent imports of day-old chicks and hatching eggs. Next slide, please. We also have the perspective to develop the public-private partnership for the sustainability of the mix, because now the project is at the end. We need to sustain this mix and systematically control everything entering into the Beninese territory, even if it's a really big task to deal with. Next slide, please. So some lesson learned and key takeaway messages. Next. Firstly, establishing strong and effective policies seems essential to tackle antimicrobial resistance. We need active collaboration and engagement with stakeholders if we want to play a pivotal role in our effort, because research is research, but they are the ones to put our evidence into action. So we need to incorporate scientific evidence into policy development that will ensure informed and impactful decision. We need to recognize and address these challenges within informal system, and it's remaining a critical focus. And also the capacity building and resource mobilization through government budget and partnership seems essential. Next slide, please. The implementation of the mix in Benin is a strategical, promising initiative, and we think that the results found in this project lay down the foundation for a successful implementation. And also, the commitment of stakeholders, including the poultry sector and government authority, demonstrate a collective will to address this issue relating to the quality of imported poultry product. Next slide, please. Next slide. Thank you very much. And it's the time to thank all the partners. You can go to the next slide where we have all the different partners involved in this project. Thank you very much.
Thank you very much for this presentation, Victoria. All clear. And it was nice to see this example in poultry. Now we will move with two different ICARS-supported projects that focus on the human sector. I remind everyone to ask any question that you have in the Q&A box. We will have time at the end of this webinar as part of the panel session to respond to any of your questions in live. So please do not hesitate to ask your questions in the Q&A box in French, Spanish, or English. Now I would like to welcome Dr. Marika Tsereteli, who is going to share her experience from Georgia on how to bridge science and policy. Marika, the floor is yours.
Thank you. Thank you, Rodolphe. I am Marika Tsereteli, infectious disease specialist and project coordinator of first ICARS project in Georgia, which is about surgical antibiotic prophylaxis. Next slide. And I want to share how we share Georgian experience, how we moved from evidence to policy in the framework of framework and through the project. Next, please. So it was very important in the process and in the beginning of the preparation of the project, which began in May 2020, to have also the memorandum of understanding. Next, please. So the memorandum of understanding is an establishment of a partnership between ICARS and the ministries of health and agriculture, which was a kind of guarantee that ministries will support all the results and the goals which would be achieved in the through the project. Next, please. So after this, we began also the background checking about the consumption of antibiotics and the situation about the AMR, because it was the first stewardship project also in Georgia. So as you see, the use of cephalosporins is quite high in Georgia, and especially the third generation cephalosporins, and very low first and second generation cephalosporins. Next. Next slide. And we studied the medical charts randomly from 35 hospitals in Tbilisi, where we saw that incorrect antibiotic for surgical antibiotic prophylaxis was used in 55%, and prolonged the surgical antibiotic prophylaxis was in 80%. Next. So we began implementation phase, which we began with ethical approval and as administrative task. Then the surgical antibiotic prophylaxis guideline was developed and approved by the Ministry of Health. Preparatory work was started with the data collection tools and data collection in 3 phases, 3 hospitals, next 4 hospitals, and another 3 hospitals. And in the end, it was summary of quality improvement, qualitative and economic results. Next. The main goal of the project was to improve the quality of use of antibiotics for surgical antibiotic prophylaxis in the nominated departments in selected Georgian hospitals by achieving within the 12 months 60% of compliance with the national guidelines. And one of the secondary goals was to ensure the sustainability of the antimicrobial stewardship program in the long term. So this is where we had to use the problem, where we had to move from evidence to policy and be strong in the policy. Next. In the beginning, of course, we had we developed a lot of data collection tools such as perioperative data collection, surgical site infection surveillance data collection, and point prevalence survey. We conducted the trainings as for epidemiologists, so for the medical staff, surgeons, nurses, and almost all the staff in the hospitals. Next, and we had also the focus groups in the project to have some overview about the behavioral. So in the end, after 12 months, we had quite good results. As you see, in 6 hospitals from 10, we began full compliance to the national guidelines from 0, and we ended more than 60%. Quite good results and evidence. Next. And in the project was also aligned in line with the strategic objectives of the WHO Global Action Plan, as well as with the Georgian National Action Plan on AMR. And it addressed the main objectives of the Georgian National Action Plan, such as the strengthening surveillance by implementing surgical site infection surveillance, and ensure rational use of antibiotics by implementing evidence-based guidelines and optimize practice in relation to surgical antibiotic prophylaxis, incorporating continuous audits and feedbacks, and increase national awareness and improve knowledge of antibiotic resistance and antibiotics use. Next. So one of the main outputs of the project in the end is the inclusion of surgical antibiotic prophylaxis in the national strategy and national action plan on national AMR 2024-2030 and in action plan 2024-2026. Next. So the take-home messages from my presentation will be the development of policy briefs is very important for a nationwide scale-up for the implementation of antimicrobial stewardship program in surgical antibiotic prophylaxis. And results and lessons learned from the project facilitated evidence-based decision-making at the ministerial level to achieve implementation of a national antimicrobial stewardship program on surgical antibiotic prophylaxis and to include it in national strategy and national action plan. Thank you for your attention.
Thank you so much, Marika at Tsereteli. And I think you have allowed us to catch up a little bit on the delay. So thanks for this. I see questions keep flowing in the Q&A box. Please continue to do so. You're very welcome. Now I would like to transition with the experience sharing from Kosovo. Professor Raka, the floor is yours.
Thank you very much, Rodolfo. Thank you for the opportunity to share experiences of ICARS from Kosovo, although we are at the beginning of the process. Next slide, please. So my title of presentation will be setting the stage to change policies about our initial steps in AMR mitigation journey. And I am coordinator of ICARS project in Kosovo. I'm speaking on behalf of my team here. Next slide. This is the title of our project. It's addressing antibiotic overuse through continuous quality improvement, developing and assessing stewardship intervention in primary care in Kosovo. And it is implemented by can you go back, please? It is implemented by National Institute of Public Health in collaboration with Evidence Synthesis Group, University of Pristina, Faculty of Medicine, and UBT College. And as you can see, we also have a mascot we prepared for the project. It is Godness on throne. It is most precious artifact in Kosovo, symbolically holding the key of antibiotic box. So this was selected as mascot for our project. Next slide, please. So we started just this year. We are at the beginning compared to Georgia that already finished their project already. Project started officially in February. And we are now finalizing all protocols of the project. And we also had a memorandum of understanding signed by ICARS representative, Robert Skow, was in Kosovo. And he signed the memorandum with 3 ministers of the Kosovo government. You can see the ceremony of signature with Minister of Health, Minister of Agriculture, and Ministry of Environment, who are addressing the cross-sectoral challenge of AMR. Next slide, please. So what is the aim of our project? The aim is to improve the appropriate use of antibiotics for acute respiratory tract infections by implementing an antimicrobial stewardship program in primary healthcare facilities. And our project targets, initially they were higher, but after the consultation with the key stakeholder on the bottom, as Sujit mentioned, we discussed it with 80% of directors in primary care facilities, and then we took their median average to put as our targets. So the targets will be to reduce the use of all antibiotics for upper respiratory tract infection by 20%, and to reduce the ceftriaxone by 30%. Because based on consumption data that we are participating since 12-11, this is one of the main challenges. And for years, we were a European leader in parenteral use of ceftriaxone. And that's why we selected exactly this challenge to address with ICARS project. And during the co-development stage, I would say it was a unique experience compared to other projects that our core team was involved. We also did a rapid assessment, and it was confirmed that ceftriaxone is unfortunately still #1 antibiotic prescribed, even in primary care. Next slide. So this is theory of change covering work packages, interventions, and outcomes. Work package 1 is about situation analysis. Work package 2 is implementation of antimicrobial stewardship. Other packages are dealing with qualitative study and conjoint analysis, and also economic analysis, whereas the final work package is dissemination to inform strategies, policies, and direction for Ministry of Health. Next slide. So, so far, what was main achievement? We wrote in our project that initial step would be to establish sustainable structure. So we should have structures for antimicrobial stewardship, both at national and facility level. So ICARS project was a catalyst for change. That's why we put on title here, convincing government to change policies, which is not easy. It's tough, tough task, but we realized that political commitment is probably the most important component in addressing AMR, because if you will have committed policymakers, they will put AMR on national agenda. They will provide funding, so resources, financial resources, and they will also drive the implementation program in all levels, from primary care to hospital. The next important component is also because commitment facilitates creation or development of frameworks, including legal framework, including national action plan, and also including cross-sectorial collaboration. So in our project, we wrote that initially we are going to establish technical working group within National AMR Committee, which is the main body to implement every policy in AMR. So in meantime, in August, this working group was established with clear terms of reference, and the work package leader of our project, second work package about antimicrobial stewardship, is chairing this technical working group now. The second step, important step, was to prepare and to establish AMS teams in primary care facilities. And we wanted to give legal power. That's why through the advocacy meeting with the Minister of Health and Permanent Secretary, it was established a group to prepare as SOP, and core members of our project were enrolled in that, and we prepared it and submitted to Minister of Health. Approval, and the initial idea was to prepare it for 6 facilities that are participating in our project. But approval of this document will establish an antimicrobial stewardship group, not only in these 6 facilities, but throughout the country in 38 municipalities. And this will enable the scaling up of antimicrobial stewardship even from the project inception. Our idea was we will do it at the end, but it is happening at the beginning. The other important component that I mentioned is legal framework. In Kosovo, we called it administrative instruction. And this administrative instruction covering AMR, One Health concept, IPC and patient safety, it is joint administrative instruction, is now submitted to Ministry of Health, is in public discussion. I would also like to mention the other components, such as National Action Plan for AMR, and also recently we just completed roadmap for AMR with ECDC within a project for Western Balkan country as first Western Balkan country, and we also a draft of this roadmap we shared with all our strategic partners to avoid, as Sujit mentioned, to avoid duplication. So we shared it with ICARS team, we shared it with WHO, with the World Bank, and Robert Koch Institute, with institutions that we have good collaboration. Next slide, please. Another important component was mentioned already by Sujit, and we did it during this time, breaking the silos. So AMR is not a task or job for healthcare workers. That's why the idea was, and we shared that idea, to expand the AMR beyond healthcare into communities, to involve communities. In this slide, you can see the proposed structure, initial proposed structure, how was in project, with 5 members in the AMS team. But during the co-development stage, together with stakeholders and together with ICARS team, we decided to include a community representative, an authority, respectful in community, to be part of this AMS team. So AMR this way should not be confined only to healthcare workers, and this will encourage collective action and shared responsibility in tackling AMR. Next slide. AMS interventions, here are interventions that are going to take place throughout the project, and these interventions we definitely think we will bridge the gap between science and policy, starting with education and training of healthcare workers in AMS through developing curriculum. We are also at the final stage of that, educating patients and prescribers for through antibiotic-free leaflets, especially for patients who are not going to receive antibiotics after the visiting the doctor. Then evidence-based practices and continuous monitoring through PPS and clinical audits. And also we will introduce rapid strep test. The other component here is work package related to economic analysis. So we are going to do also analysis of cost of savings and cost of implementing AMS in primary healthcare centers. Next, although we are at the beginning, at the first year, nevertheless, we managed to already prepare 2 manuscripts ready for submission. One is dealing with clinical and non-clinical decision-making for antibiotic prescription for tonsillopharyngitis in Kosovo, and this is conjoint analysis study protocol. The other protocol is protocol for qualitative assessment of enablers and barriers in implementing and scaling up AMS for upper respiratory tract infection in primary care. And there is also discussion to publish our results from rapid assessment during the co-development stage as a short communication in other journal. Next slide. So I thank you for your attention, and I would like also to thank again ICARS for tremendous work and supporting Kosovo with some pictures from my country. And last slide is I would like to acknowledge all team members of the project, both in Pristina here, but also in Copenhagen. Thank you very much.
Thank you so much, Professor Raka, and thanks to all 3 guest speakers from 3 countries that ICARS is supporting to look for solutions to AMR. Now we will start the panel session. We will have about 15 minutes, a little bit less, to address some of the questions that we have received in the Q&A box, plus a few others that will try to go a little bit deeper into how we bridge science and policy. Can I get confirmation that Victoria is... Yes, you're here as well.
Yes,
perfect.
yeah.
Excellent, excellent. So I think your presentation triggered quite some interest from the participants. And let's start with the questions from Sherfal. So can you let us know if the results from the mixed study has revealed some critical situations from chicks and eggs, I guess those imported into Benin, And what are the decisions developed by the local authorities? You already mentioned that a bit, authorization, incineration. I don't know if you can elaborate on that.
Yeah, thank you very much. Yes, the mixed study revealed some critical situation. We have some chicks that are carrying quite a lot of resistance through also the eggs, the hatching eggs. So the key decision is that, okay, when we have such situation, we can discard the products, or we can give an authorization, or we can give a warning, because if the critical level are not yet achieved, then we just give a warning saying that, okay, now you have to take care more on the next batches. So that's what we define. And the local authorities were really concerned by this topic, you know. Firstly, they are promoting the local production of chicks, day-old chicks, and those eggs, so that we ban the importation, the imports. That's, I think, one decision that will start in December. So we hope to put together this new decision and what we have already defined through our mix. And we hope that together we will solve the issue. Thank you.
Thanks a lot, Victoria. So the decision is still to be taken in practice, and it was still at the stage of the study. There was a second question as a follow-up. How do you make this mixed system sustainable, and how do you have any recommendation on how to extend it to other countries?
Yeah, how to make it sustainable? The first step is the support from the ministry in charge of that question. And in this case, the Ministry of Agriculture is really, really, really willing to use this mix, even more than us researcher. So now we don't want to put ourselves in front of everything. So now we are putting the Directorate of Livestock to be the main responsible of the activities. We as researchers, we are just the supports. And like that, they feel involved in the process. The second way to make it sustainable is that the system funds the mix itself. And that's what we are defining. The system is funding it itself. So I think those two examples can extend it overseas, and we are really happy to share any ideas regarding that, if it can be operated overseas. Thank you.
Thanks a lot for offering your help. And so as I understand, one of the key aspects was to get the commitment from the government, or the strong motivation from the government at the very beginning. And maybe that leads to another question to all three panelists: is how do you convince governments that some policies need to be changed? You have already a bit touched on that in your different presentations, but if you could go a little bit deeper, like how did it start? Was it you who started to convince the government? Was it the government who came to you a little bit like in Benin? I'm wondering for Georgia and Kosovo, how do you convince governments to make policies? Marika.
I will begin. Today I'm representing National Center for Disease Control and Public Health. It is also a governmental organization, but we still need to show to the government and Ministry of Health some data to calculate everything, to show them and convince with the data that it is working. We need some policies about it. This is the main thing. If we have enough data for them, then we could go and work with them. This is absolutely vital. Thank you.
So data. Great. Professor Raka.
Thank you for the question. This is a very important topic, and you have to go to government. Government will not come to you. It's very rare that government are going to invite experts, but they will invite only when there is an outbreak or problem. Otherwise, in normal circumstances, you have to convince them. And how to convince them? I think, first of all, you should understand the landscape, existing policies. In my country, which is a small country, 1.5 million 1 million inhabitants, you need to cultivate relationship and to build trust. So in a small country where everyone knows everyone, I had the opportunity to work with all ministers in this. And I also, one advantage was probably trust created with different governments during the COVID time. And then to convince them to invest, for example, in laboratory capacities. Marika also mentioned evidence base. So you should use those data that are not popular to change the policy. For us, those data were and still are huge misuse of ceftriaxone, although during this period of time, we had dramatic decrease of total consumption of antibiotics, but we still are among the first in Europe for ceftriaxone. And also it is important to clarify, to convince government they are more interested on local picture, not on global. You can say this is global problem. This is the situation in the world. This is the situation for inaction. But they are interested in Kosovo. What is the problem here? What is our local context? So it is very important to take into consideration that, and also to mention some impact. For example, AMR, for some people and policymakers would look abstract, but if you tell them it hits everyone, it is going to hit people with cancer. They will have multi-resistant infections. They will die from infection, not from cancer. If you show them that, look, we have, for example, in my country, we had carbapenem-resistant and Acinetobacter among newborns. This is totally unacceptable. We have to change that. The other component is to share best practices in the world. So we don't have to invent the wheel. We just take best examples, adapt to our context, and implement them. Also, the proposals that you have to convince them have to be realistic regarding the budget. And also sometimes one way is to make pressure through media for some activities that don't move or they are continuous. For example, some challenges with over-the-counter sale. And it is important also to address every resistance that is seen on the field. So you will have resistance for the moment. Pharmaceutical industry is very strong. It is not easy work to address that, but you should give proposed solutions, best solution for every challenge that you have. So these are most of them that were specific to our context and important.
Thanks a lot, Professor. I think it's kind of a manual on how to convince governments to make changes with all your suggestions. I think we can feel the experience, and it's quite promising also for the project supported by ICARS. I received some questions which were a little bit technical related to the project in Benin. I think my colleagues are responding directly in the chat. There is still one question from Benin, from Arno Soa, intended to Professor Raka again. What were the different structural challenges encountered in setting up this system, and how did you manage to get all the involved stakeholders to easily buy in to the project, to the system?
Well, besides creating the trust, it is also to involve all stakeholders all together, to have a collaboration or cooperation, communication. Without that, you can have the best project, but in implementation, you will fail. So it is important to hear every voice. not only from Minister of Health or Prime Minister, but also from the doctor who is working on the village. So from people from the first line, or from the doctor who is working in a hospital, in surgery theater. See what are his challenges and how is the best way to address it. So I think this is very important component to put them together, to hear every voice, to have a normal discussion, and to come up with best possible solution for the local context. So never local context should never be forgotten, and it's very important.
Excellent. Thanks a lot, everyone. I can see that we are running out of time, so I think we will have to close the meeting. There were some pending questions that we will try to respond. I don't know if we will be able to respond in live everything. Oh, there's maybe one question for Marika Tsereteli. What were the key steps? Okay, maybe one last one to save this webinar for you, Marika. What were the key steps and possible challenges encountered in integrating SAP, so the surgical antibiotic prophylaxis protocol guidelines, into the NAP 2024-2030 within the action plan 2024-2026? Wow, there's a lot of dates. Maybe you can respond to this, Marika.
Yeah. So it was a real challenge. We had to work a lot with the ministry because it's quite large. The strategy is quite large, and but we needed to put there our surgical antibiotic prophylaxis as one or more bullets to have the future further surveillance in that years. So what I had to do was I took part in a lot of meetings. I had all the presentations from the 10 hospitals and presented them and had the backing and support from the National Center for Disease Control and Public Health. This was very important.
Thank you so much. I think it is time to conclude this very interesting webinar. Thanks a lot to all our speakers. I think we have learned a lot on how to bridge the gap between science and policy. And I think we learn a lot as we go. A lot of information is generated through all your experience. So I hope we have been able to answer all questions. So in the Q&A, thanks everyone for your attention. And I hope you will enjoy the rest of this World AMR Awareness Week, which is a very important event to raise awareness, everyone, and share what we experience in AMR work. Thanks a lot, everyone.
Bye-bye. Thank you.
Thank you, and bye-bye.
Goodbye.
Bye-bye.
Yeah.
Good luck with your projects.
Thank you.